Electrocardiography, ECG, is one of the fastest ways I can understand what the heart's electrical system is doing in real time. In this quick explainer, I'll show how ECG helps diagnose arrhythmias, ischemia, and myocardial infarction, and how to approach interpretation like a clinician. First, principles. An ECG records electrical activity across multiple leads. P wave, atrial depolarization. QRS complex, ventricular depolarization. T wave, ventricular repolarization. PR interval, AV, nodal conduction. QRS duration, intraventricular conduction. QT, total depolarization-repolarization time. Arrhythmias, start with rhythm and rate. Normal sinus rhythm. Upright P waves in lead 2, consistent PR, narrow QRS. Atrial fibrillation, irregular, absent organized P waves, fibrillatory baseline. Supraventricular tachycardia, regular narrow complex tachycardia, often without visible P waves. Ventricular tachycardia, wide complex tachycardia, AV dissociation, capture or fusion beats. Treat as VT until proven otherwise. First-degree AV block, prolonged PR, 200 nanometers with 1.1 conduction. Mobitz Y, Venkabach, progressive PR lengthening then a dropped beat. Mobitz II, fixed PR with intermittent non-conducted P waves. Third-degree block, complete AV dissociation with escape rhythm. Ischemia. Look for horizontal or downsloping ST depression. Look for symmetric T-wave inversion in contiguous leads. These changes are dynamic. Compare with prior ECGs and correlate with symptoms and troponins. Myocardial infarction. Acute transmural injury. ST elevation in contiguous leads with reciprocal depression. Early hyperacute broad T waves can precede ST elevation. Over hours to days, ST segments may normalize while pathological Q waves appear. Inferior. 2, 3, AVF, RCA, LCX. Lateral. I, AVL, V5, V6, LCX, diagonal. Anterior, septal, V1, V4, LAD. Posterior, MI, V1, V3, ST depression with tall R waves. Confirm with posterior leads, V7, V9. How I interpret an ECG, step by step. Confirm patient, date, and calibration. Rate and rhythm. Axis. Intervals. PR, QRS duration, QT, QTC. Morphology. P waves, QRS patterns, Q waves. STT segments. Elevation, depression, inversion, concordance. Compare with prior tracings and the clinical story. Clinical significance. Activating the cath lab for STEMI. Initiating antiplatelets and anticoagulation. Choosing cardioversion versus antiarrhythmics. Pacing for high-grade block. In the ambulance, emergency department, or ICU, those first 10 seconds at the bedside can change outcomes. Bottom line, every heartbeat tells a story. ECG lets me read it. Master the waveform, recognize the patterns, and always interpret in context. Electrocardiography, the heartbeat of cardiovascular diagnosis.